I think we'll go ahead and get started. So it's a pleasure to introduce Katja Kiseljak-Vassiliades. And with that last name, I've had to practice, even though I've known Katja for a long time. But I'm also told that her patients call her Dr. K. Is that right? So anyway, Katja got her bachelor's at Bethany College in Kansas, and then her DO from Midwestern University in Arizona. She then did her residency in internal medicine at Johns Hopkins, where she became chief resident, and this is also when she actually started working on thyroid cancer with Mingzhao Jing, I think, there. She was recruited to the endocrinology fellowship program here at the University of Colorado back in 2009, and for her fellowship studies, she worked with Dr. Maggie Weirman on pituitary tumorigenesis. She is now assistant professor in the Division of Endocrinology and is working on adrenal cancer, for which she'll tell you today few therapies exist, and this is a very rare cancer. It also has a very poor prognosis. And so another thing that Katja will talk about is adrenal cancer really has very few mutations or genetic changes, so really alternative therapeutic strategies or alternative therapeutic targets are needed. And Katja's done a great job using gene expression and bioinformatics approaches to identify new targets, and also doing some tumor immunology approaches, which I think she'll also talk about. And then just another challenge with adrenal cancer is really the lack of preclinical models. And so Katja's really been working diligently on developing some of these new models for adrenal cancer. In terms of honors and awards, Katja was awarded a Young Investigator Award from Women in Endocrinology for an outstanding abstract from the Endocrine Society a few years ago. And Katja is currently funded by the Paul Calabresi K-12 Award and is working hard on American Cancer Society and NIH mentored research grants. So today she is going to talk about adrenal cancer and insights into the orphan malignancy.
Great. Can you hear me? Yes? Okay. Thank you for this nice introduction, Rebecca. So adrenal cancer is really a rare cancer. The incidence is about 1 per million, and there are about 500 people diagnosed with adrenal cancer in the United States. So the incidence might actually be a little bit more frequent than stated here. Here is an example of a patient with adrenal cancer, and this is a coronal view of a patient. Here is the liver, these are the lungs, heart, and here this big lesion here is adrenal cancer. So you can see this is a huge tumor, and this is not, this is actually what they present like. They present with the tumors 10, 20, up to 30 centimeters. Patients present with very big disease. So the treatment options are limited, and the first line treatment is surgical therapy, and that's when that's possible, when the tumor is not invading all the organs and vessels. And I think probably about 60 to 70% of patients do undergo the surgical resection. Myritin is the FDA-approved medication, and it's an insecticide-derived adrenolipid. It's the only FDA-approved medication, and it's really more so static than cytal. Chemotherapy for metastatic disease has limited effect, about 20% response, 50% if stable disease is included, and the 5-year survival in these patients is less than 35%. There are no targeted therapies that are available, and new therapies for these patients are desperately needed. So this is how patients usually present with adrenal cancer to a clinic. About 40 to 60% of patients present with signs and symptoms of hormone overproduction. So adrenal cancer is an endocrine tumor, and endocrine tumors can produce hormones. If the patient's hormone production is cortisol, they present with Cushing's syndrome, and this is an example of patient that has overproduction of cortisol. They have this central obesity with stria, they have the dorsal cervical a fat pad, and then this moon face is sort of a plumpness of the face. Some patients also present with high testosterone, and in women, that's usually acne. They get male pattern baldnesses, things like that. And very rarely they present with high aldosteronism or high estrogen. About a third of patients don't have any hormone production, and they present really with structural abnormalities, fullness, flank pain, early satiety, and then about a third of patients actually presented incidental finding. Even with the large tumor, as I showed before, they actually can live and have not a lot of symptoms until they have a CAT scan for something that is not related. So majority of adrenal cancer tumors are sporadic, but there are several genetic and germline mutations that are associated with adrenal cancer. Liframen is one of them, Lynch syndrome, MEN1. It is important to note also that liframen, which is really a p53 mutation, there is a founder mutation that is present in Brazilian population, and there the incidence of adrenal cancer in pediatric population is actually pretty high. And it could be even up to 1 to 5,000. So this is something that is prevalent in Brazil. In sporadic tumors, we now know there are certain pathways that are seen. The Wnt pathway is seen in about 35% of the patient, and now this has been confirmed with the recent studies from a European group as well as the TCGA. And then T53 pathway is seen in about 17% of the tumors. However, neither one of these pathways have been successfully targeted in adrenal cancer or any other. So these are what are the treatment modalities. So the surgical resection is first-line treatment. The big issue for this patient is that about 45% of patients have the surgery done in community hospitals. And since this is a rare disease and the expertise is really needed, the surgery that is done outside, usually the surgeons do not recognize this could be an adrenal cancer, so the surgeries are sometimes done suboptimally, occasionally laparoscopically. The tumors could burst and seed inside the abdominal cavity, and then they present to then the patients present to an expert center. So that's still a big problem in the field. About 30% of the surgeries happen in academic centers, and only in about 15% in NCI-designated cancer center. In patients that have high cortisols, we usually manage hypercortisolism with drugs, and then mitotane. And there's still limited data whether mitotane is useful in sort of adjuvant setting in patients with high-risk disease. And so mitotane, although it's an FDA-approved medication, it's still in the clinical trials to evaluate its efficacy. There's about 30% patients that show stable disease, and the chemotherapy, which is etoposide, doxorubicin, and cisplatin, about 20% response, and the progression-free survival is 5%. Several targeted therapies were tried. The IGF-1R, an insulin receptor inhibitor, was tried in a clinical trial a few years ago because IGF-2 is the most upregulated gene in these cancers, but this failed. And there were also several sort of tyrosine kinase inhibitors and multi-kinase inhibitors that were tried, not very successfully. So the biggest issue in the field has been that there are really limited models. In vitro, there is a cell line that was derived about 40 years ago from an adrenal cancer met. It's called H295R, and this is the cell line that really all the literature has been using. Subsequently, several other cell lines have been developed. Some of them we're actually not even sure if it's adrenal, like this SW13 is probably a lung cancer cell line. And then some of these other ones are not really adrenal cancer. They're from the different sort of adrenal type of disease, and they have not been used because they're not available. Recently, a German group derived this MAC1 cell line from an adrenal met in the neck, but has not been used yet in any other studies. In vivo, H295R xenografts have been used. And about 4 years ago, a group from St. Jude reported a PDX from a pediatric patient that was only used in that study, but not subsequently. So the models are needed. So when we start seeing patients with adrenal cancer about 3-4 years ago, we were just amazed how little is known and how little treatments are available. We were actually very sad that a lot of these patients were just dying. And so we decided to open a multidisciplinary clinic with Dr. Wehrman and Dr. Leong. And with leadership, also with Todd Pitts, we decided to do some of these goals. We decided to establish ACC tumor bank, to develop new models, in vitro and in vivo, and to identify some new targets. And we were initially pretty discouraged from people in the field because they said in the last 4 decades since the initial cell line was developed, many people have tried and were not successful. And one of the reasons being that the tumors produce cortisol, and a lot of times mice just died from hypercortisolemia. However, we decided to do it anyway. So using a model system that was used by Dr. Rebecca Schweppe, who helped us with this a lot, we used feeder cells, and these are 3T3 NIH-irradiated fibroblasts and ROCK inhibitor. We took fine needle aspirations, basically just would take a needle into the tumor, fresh tumor that was just in OR, and would put these then cells into the dish with feeder cells or onto the just plastic. And at the same time, we would also take a piece of tumor from the patient, and we would put it into the mice. And this was to derive the patient-derived xenograft. And then the tumors would grow, and once the tumors would grow, then we would also again do the fine needle aspiration and again do it on the dish. And so most of the times, we were not successful going directly from the OR into the dish, but when we passaged the tumor through the mouse, nude mouse, we were successful to derive several cell lines. So Stacy Bagby was really instrumental in starting this, and for the first patient that we've done, we implanted in September of 2015, and we passaged first in 3 months, which is pretty fast compared to some other malignancies they have done in the lab. And for the second one, it was implanted in October, and then it passaged in March. So that was all pretty good. And then we were able to derive the cell lines from this. From the ACC1, we were able to do this group pretty fast. This one, it took a few times to passage the mice until we got a cell line. So then we performed short tandem repeats to make sure that the cell lines and the PDX match original tumor, and that looked pretty good here on 1 and 2. And speciation looked just to make sure that the cell line is not contaminated with mice. And here is one of the ones that then were used for propagation for 1, and this one for 2. Next, we wanted to make sure that our PDX tumors histologically resemble the original tumors, and we did some of the markers for adrenal cancer. As you can see, H&E, the structural, there is a resemblance between the PDX and tumor, and then these are some of the markers that we used in the clinic. Melan-A was similar. Alpha inhibin is one of the markers of adrenal, and then MSH2 we checked, and that's one of the markers when we look for Lynch syndrome, and I'll show you this in the next one. So our patient, ACC2, had Lynch syndrome, and they had a mutation, basically deletion of first 6 exons of MSH2 in basically mismatch repair. So in this patient and the mice, there is a loss of MSH2. Alpha inhibin is there. There is some loss of Melan-A in PDX compared to the human tumor, and then H&E structurally pretty similar. We then performed extensive profiling. This has just been recently published in endocrine-related cancer. And Nikita Pozdeyev really led some of this effort on exomic sequencing. We looked at the mutations that are present in adrenal cancer and found that in our one model, the beta-catenin mutation was present that was predicted to be damaging, and there is enrichment of the damaging allele going from tumor to the cells, and ACC2 had a mutation in TP53. The RNA-seq was also performed and showed a nice clustering of the models with human tissue and upregulation of genes associated with adrenal cancer. And then we also performed secretory profiles where we looked at hormones, and we found that ACC1 secretes cortisol. So then, once we developed these models, we thought we had something in our hands to maybe look at some drug targets, because that is our ultimate goal. Our ultimate goal is to bring new targets to the clinic. So I'm going to divide this talk in two different things. We're going to talk a little bit about kinases and then some slides on immunotherapy. So we performed analysis of publicly available RNA expression using the microarray expression that is available in the literature, and there were 2 or 3 studies there. And we were able to batch correct for that, and as you can see here on this PCA plot, these red are tumors and the blue are normal, and there is a nice separation of tumor versus normal. We also took data from the TCGA. They had 77 adrenal cancers, and data from the GTX project. And GTX project is a broad project that took normal adrenal. And so we took both of the RNA-seq data from the FASTQ files and then together ran them through the pipeline, and Ken Jones did that to help us with that. We looked at upregulated genes in analysis of RNA-seq and microarray data, and we overlapped them and we found there are 114 genes that are in common. And then we looked at the kinases because we were interested in targets. We thought maybe we should look at the kinases first, and our thought was that maybe we should try to target genes that are related to DNA damage repair. And so we identified 2 kinases that were highly upregulated in ACC compared to normal. And so I'm going to talk a little bit more about these kinases. So maternal embryonic leucine kinase was identified as highly overexpressed in at least in subset of ACC compared to normal. It's 8-fold on this microarray data, and then again here on TCGA there are some that have very big upregulation of MELK. And then when we looked at our protein, here representative samples where we have performed IHC of 18 ACC that we have in our bank, and they all they show about 60 to 80% of them show upregulation of MELK compared to normal adrenal. So what is MELK? It's a cycles-dependent protein kinase. It's expressed in multipotent neural progenitor cells, and it's been shown to regulate proliferation, differentiation, and apoptosis, and has a role in cell cycle, and it's been shown to be upregulated in several cancers: breast cancer, melanoma, glioblastoma. And importantly, there is already a MELK inhibitor that is available and has been started in clinical trial in Chicago that the results are not available yet in solid tumors. So it's sort of all comers as 8th, 9th line chemotherapy or targeted therapy. We also looked here at the TCGA data, and this is clinical data, and we looked at MELK as it relates to the death from the initial pathologic diagnosis. And you can see here when MELK is higher, the patients die sooner. So it suggests that MELK is inversely related with survival. And then when you look at the data from the European group who looked at these aggressive and less aggressive adrenal cancer, you can see that in patients that have more aggressive adrenal cancer, MELK is higher. So some of this data on MELK has been done by our PRA in lab, Yu Zhang, and we wanted to look at how MELK is associated with cell cycle related protein in ACC. So we performed a co-regulation analysis where we looked at the TCGA data set on transcript level and see which genes that are related to cell cycle are co-regulated with MELK with a high significance. And we found several genes, and then we looked at these genes and MELK in our models. So here is MELK, BAB1B, polo-like kinase, FOXM1, and here in black is H295R, the commercially available cell line, and these other 2 are our cell lines that we have developed. And as you can see, there's a correlation with MELK upregulation and some of these cell cycle genes on the transcript level down here. And then as well on the protein, we looked at some of these selected genes, and we can see also correlation on the protein. MELK was reported to be interacting with FOXM1, and so we used a FOXM1 inhibitor to see if we inhibit FOXM1, how MELK is going to look. And here is the TCGA data where you can see that FOXM1 and MELK seem to be highly correlated. When we inhibited FOXM1 with a FOXM1 inhibitor, there is also a proportional decrease in MELK, suggesting that FOXM1 might be upstream of MELK. Since we are interested in therapeutics, we got MELK inhibitor and looked at proliferation and clonogenicity. So here is the MELK expression in our H295R, ACC1 and 2. And so it's mostly overexpressed in H295R. And then looking at proliferation, there is a dose-dependent decrease in proliferation on the cell lines. And as you can see here, because you cannot see the doses here, they're pretty small, but the H295R cell lines that have the highest MELK are really the most sensitive to the inhibitor, suggesting some specificity of this inhibitor to MELK. Next, we looked at apoptosis, and similarly here, there is a dose-dependent increase in apoptosis, looked here as indexes cleaved PARP and cleaved caspase 3. And again, the H295R cells seem to be more sensitive than ACC1 and ACC2. So then to look at the specificity of MELK, we silenced MELK in our cell line. Since H295R have the highest expression, we used two different constructs, SH1 and SH-MELK2. And you can see we've got a pretty good silencing. And then we looked at the proliferation, and there is a decrease in proliferation with silencing of MELK. And then we also looked at tumor genicity. We looked at anchorage-independent growth here by soft agar, and there is a decrease in colony formation in SH-MELK1 and 2 compared to control, as well as in clonogenicity assay here. We also looked at apoptosis, and while silencing of MELK did not have an effect on apoptosis in normoxic environment, when we put the cells into sort of very harsh conditions, hypoxia and serum deprivation, we found increase in cleaved PARP and caspase 3. And as well as increase PARP, tunnel staining also as an index of apoptosis. And this, again, was only seen in harsh environment with 0% serum and hypoxia. MELK and members of MELK family have been reported to act in sort of harsh condition. We then performed some in vivo studies, and these were done with Adhikar and the postdoc in the lab, and help with Stacy. We used our models that we have developed, ACC1, as well as our unpublished model, ACC9. And here you can see the MELK expression in this model. So as you can see, well, ACC1 cell line really had very little MELK. It looks like there was some dedifferential on the plastic. The PDXs actually have pretty good expression of MELK. Once the animals were treated with MELK inhibitor, 5 days a week by oral gavage, you can see that there is a significant tumor growth inhibition in the animals treated with MELK inhibitor for ACC1 and ACC2. And here down there are the individual plots. So that's the MELK story. We also looked at the other kinase, and that's PBK, and I'm just going to spend a little time here. This is PDZ binding kinase. Again, it's actually even more upregulated in adrenal cancer compared to normal, and also associated with prognosis. So higher PBK, worse prognosis. This is MAPK, like threonine kinase. It's also involved in the cell cycle. It's overexpressed in several cancers and also drives proliferation, survival, and tumorigenesis. And there is a small molecule inhibitor that we have, but this has not been tried yet in any of the clinical trials. So Adhikar really did most of these studies. First, we looked at the BBK expression in our cell lines, and you can see that some of the cell lines have higher expression. And when we looked at our patient tumors by a Western blot, actually most of our tumors have a high PBK expression. More tumors have higher PBK expression than MELK expression. We then took the high top K, the PBK inhibitor, and we looked at the clonogenicity. And we found that there's a dose-dependent decrease in colony formation in all of the cell lines. We then silenced PBK, similarly like with the MELK story, and we actually got the best silencing in H295R cells. And as you can see here, we got actually the best response with colony formation in this cell as well, which might suggest that this high top K is sort of that high top K mediated inhibition is dependent on the loss of PBK inhibitor. Then Addy took this into the vivo experiments, and as you can see here, similar to milk, when we added a high top K, and here again the treatment is 5 days a week, oral gavage, there was significant decrease in tumor growth, more like static effect, and here are the tumors that are treated, and here is the controls. So just a summary of this mitotic kinase, the bioinformatic analysis of the public data sets identify a couple of kinases, and we have found that they are correlated with worse prognosis in the patients. And this in vitro and in vivo study suggests that they might play an important role in promoting tumorigenesis. There is a MELK inhibitor that is already in the studies on just solid tumors, and we would like to try it here in phase 1 studies for patients with ACC, and those efforts are now going to be done with us and Dr. Stephen Leong. The other inhibitor, the HYPTOK, since it has not been used in clinical trials yet, there are further efforts to look at the toxicity studies in the animals before we can proceed to that. Okay, so now I'm going to shift gears to some of the immune therapy and some of the immune things that we have been looking with adrenal cancer. So this is just a reminder for people that are not immunologists in the audience. So the antigen from a tumor cell is recognized by the antigen-presenting cell, and this is the dendritic cell in this case. And that through the bunch of signaling effects, the antigen-presenting cell finds the T cell, and then the T cell proliferates with the antigen-specific target. And then once ready, enters the bloodstream, and what really happens is the T cell recognizes this tumor cell, and the cytotoxic T cell kills the tumor cell. When the cancer has selected for the tumor cells that have this overexpression of B712 that recognizes CTL4 on T cell, or PDL1 that binds to PD1 on T cell, the tumor is able to evade the immune system, and the tumor grows. And so, as most of you know, some of these checkpoint inhibitors, the PDL1, PD1, and CTLA4 have been really now derived to help the immune system fight the tumors. When there is an immunocompetent system, this is actually the basis here, and the fundamental basis how immunocompetent system fights the newly formed neoplasms and keeps in checkpoint. So our hypothesis for this project was that PD-1 checkpoint inhibition will result in tumor growth inhibition, and our goals were to identify whether the anti-PD-1 has an effect on the ACC tumor growth. So this was done with help of Julie Lang, who really pioneered this humanized mouse model. And here, the 1 to 3 day BRGS strained pups were irradiated, and then the human CD34 hematopoietic cells are transplanted. And weeks 10 and weeks 15, we check the chimerisms in the mice, and here, as you can see, the CD45 are the human hematopoietic cells, and this is the flow plot. There is a pretty nice amount of these in these humanized mice. Then we take the mice and randomize them in 2 groups, control group and a treatment group at 15 weeks. And here is just to show that the chimerism is similar between the groups in the peripheral lymph nodes and spleen and bone marrow. So the groups look pretty equal. And the human chimerism is more than 45% in these mice. So then we take these humanized mice at 18 weeks, and we take the PDX that was originally done in our nude mouse, and we inject them in the humanized mice. And we let them grow, and once they reach at least 200 millimeter cube, we performed short tandem repeats to make sure that our mice tissue from the humanized mouse now that have been passage through the nude mice still match our original tumor. And as you can see, we still have a pretty good match. We then enter the study. So the control animals receive vehicle, and treatment animals receive pembrolizumab 30 milligrams per kilogram IP 2 times a week. And then the study goes on for 27 days, at which point the mice are sacked, and the tumors are sold for the flow cytometry and immunohistochemistry for analysis. So Ana Capasso has done these studies, and here you can see that when animals are treated with anti-PD-1, there is inhibition of the tumor growth compared to control, and here are the individual tumor plots. Then we worked with Kim Jordan in immunology, and we wanted to see what is the immune infiltration in these tumors. So these are the untreated or vehicle-treated tumors, and here are anti-PD-1 treated tumor. And as you can see here, especially on this dot plot, there is increased infiltrate in the anti-PD-1 treated tumors compared to control, CD4, CD8, some granzyme, and TIM3. Julie Lang went then on to do flow cytometry. The tumors were digested and single cell suspension was made. And as you can see here, there is an increase, there's a trend of increased tumor infiltrating lymphocytes in anti-PD-1 compared to control, and that's seen here on the flow plots. And we looked at the subtypes of the T cells in the tumor infiltrating lymphocytes, and there is a significant increase of CD8, and that's this here on the flow plot, in the anti-PD-1 compared to control. And there's a proportional decrease of CD4 in the treatment compared to control. This effect was only seen in tumor infiltrating lymphocytes, and it was not seen in other peripheral immune organs, such as lymph nodes, spleen, and bone marrow, where there is no difference between CD8s. We then looked at the activity of the T cell. HLDR is an index for T cell activity, and in tumor-infiltrating lymphocytes, in the treatment compared to control, there is an increase of HLA-DR, and here is a representative flow plot. And then granzyme B is really the index of the T cell toxicity and T cell function, and here again in CD8 cells, which is cytotoxic cells, there is an increase of granzyme B in the pembro compared to control, and here is the flow plot. So this is our ACC2 patient. Again, reminder, this is our young patient with Lynch syndrome, and so we wanted to look at patients' immune infiltration, and this is patient's IHC, and this is 7-stain multispectral fluorescent immunohistochemistry done by Dr. Kim Jordan. And you can see here that there is a significant amount of immune infiltration in CD4, CD8, some granzyme B, TIM3. And the reason we did this is because our patient has progressed. So in January 2017, our patient developed a massive liver lesion right here, as well as multiple spots in the lung, and this is a representative spot in the lung. And so based on our data, we decided to treat the patient with anti-PD-1. In only 3 months, the patient had a significant decrease in the liver lesion, and by January 2018, which is the last CAT scan done, we have a very significant decrease in both the liver and the lung. And this was done by Toshi Clark, and there was a 73% reduction in the tumor volume per RECIST 1.1. And so this is, for the adrenal cancer, remarkable. Patients in our field do not have this kind of responses, so this was presented also at Endocrine Society, where we present most of our work for adrenal cancer. And this really suggests that probably subsets of these patients might have some response to immunotherapy, and this needs to be investigated further. So in summary, the humanized mouse model provides a very useful model to study mechanisms in response to immunobased therapies, and immune checkpoint inhibitors have potential benefits in subsets of these patients. We are planning to use these models to explore predictors to immunotherapy response and also combination therapies. We are also hoping to identify mechanisms that are going to enhance the response of ACC to immunotherapy in collaboration with our colleagues from immunology. And I would like to acknowledge the people that did most of this work and without whom this work would not be possible. Stephen Leong, Anna Capasso in oncology, our adrenal team, Todd Pitts, Chris Rayburn, our surgeon, and Maria Albuya Cruz, Hilary Somerset is our pathology. Our immunology team, Julie Lang and Kimberly Jordan, and Jenna French, who is our endocrine immunologist, radiology. My mentor, Maggie Weirman, and our lab, Yu Zhang, who did a lot of milk studies, and Adi Kar, who did PBK studies, and bioinformatics, Ken Jones and Nikita Pozdeyev. Our funding, K-12, as well as great funding from Cancer League of Colorado. And of course, the biggest thank you to our patients. Isabel.
Your patient, in the last case that you presented, the patient that failed, that then responded to treatment, I missed it, maybe you said it. What was he on that he became resistant to treatment?
Yeah. So this patient was on mitotane and developed a progressive metastatic disease. And the question then became, should we put the patient on chemotherapy or should we try the anti-PD-1? And so we put the patient on anti-PD-1. After the patient was placed on anti-PD-1, not only did the tumor lesions have shrank, but she also did not have any further metastatic lesions, which was pretty amazing because they just kind of multiplied in the 6 months prior starting anti-PD-1. Yeah. So the germline leaf-Raumeni, they have obviously germline P53, but P53 separate from the leaf-Raumeni has been found in about 17% of patients. So either P53, CDK4, or some of the other genes in that pathway as a sporadic somatic mutations in tumors, totally independent from the germline. No, nothing has been used with MDM. No. So far, the way targeted therapies mostly has been kinase inhibitors. Cytotoxic chemotherapy has been really 5 patients on 5-AVU, 5 patients on gemcitabines. You know, there were no clinical trials. They were all small studies of 5 to 10 patients, and then somebody would just decide this works, it doesn't work. So very suboptimal, yeah. The new therapies now that they're trying out there in the world are cabozantinib, and they're trying that as a single agent in patients with ACC, which is not great, informed from all the other trials, but nevertheless, they think that's going to be a more clean study. And then some other people are thinking about doing anti-PD-1 as a single agent. So, yeah. And we're thinking about maybe MELK inhibitor in combination with other treatments.
So since these are like PK and MELK are mitotic kinases, do you ever see a correlation in their cell lines with mitotic index?
So, you mean like a Ki-67 or? Yeah, so, you know, we have actually treated our, obviously our in vivo models with these inhibitors. And it's the Ki-67 for these cell lines and for these models is huge. And really it's hard to see. We're actually doing some of these studies looking at a Ki-67 and whether there is any decrease. But I honestly don't think so. I mean, I think these, once you start passaging them, propagating them, Ki-67 is out of control. We are trying to find some markers that we can look at. We have been looking at maybe a little bit on the survival side, but we are, you know, looking at what markers we can actually use to show that why these tumors stop growing, and we are not able to see that. Yeah, that's what we're doing right now. We tried Cleve-PARP, right? And
the controls are very necrotic and they're very big. And then our tumor, the treated ones, they were pretty much cytostatic. So they were tiny, but I think they were still proliferating, but not maybe at that much. So we can't really much with the
So that's one of the issues that we're having. Looking at the flow at these non-synchronized cells, it doesn't make sense. But we are doing some of this cell cycle where we are arresting cells. Addie is doing that right now to look at that. But yeah, that's one of the issues that we've been when they start passaging and proliferating, Ki67 is like 90%. It's all over.